So this last part, my goal here is to sort of keep it a little lighter and a little more engaging with everybody in the room. So with cases, I will really encourage the audience to not wait or withhold your comments, but raise your hand and pipe in and say bullshit or you're stupid, especially to Alan. This is exciting because being a moderator on this panel, everyone, all 5 of my guys are sending 2 cases each, so I'd have 10 cases to go through, and it was freaking crickets. I got 0. So I want to congratulate each one of you for being. Dr. Ash looked at me, smiled like in the gym.
That's not true. I sent you a case.
I sent in 2 cases. No
all
way.
spiced. In the Jim Taboni way, he said to me, "Well, you're gonna be just fine." And then when Dr. Ash says that, I knew I was okay. So look, here we go. This, by the way, this CAT scan is a real case of a kid who the ER couldn't seem to keep in the socket. And as I found out a little more about him, he'd go ER to ER. He had a nice way to get his morphine. So the rules of engagement, gentlemen, this is for you on the panel. You have to answer the question. There's no gamesmanship, no dancing around like Dr. Frankel did yesterday. You may not ask for other films. You may want them. You may need them. You got to cowboy up and answer the questions. You may not defer treatment. I mean, we'll call Donald Trump on you. And it doesn't matter if you're, Dr. friggin' Savoy. So one of you should have been, but Rafi, that'll be you. So let's go. About 6 months ago, in the same week, I got 2 different guys who come in, and they're both 64-year-old attorneys. The guy on the right dislocated his shoulder just once. The guy on the left dislocated his shoulder, and it popped out 2 more times. So now I have 2 guys in their 60s, healthy, not athletes, but regular 60-year-olds who have had a shoulder dislocation. So I guess, Dr. Esch, what do you, look, old school, what are you doing for these guys? They're in their 60s. What's the next step?
Well, they both probably have big cuff tears. So I would evaluate their rotator cuff. I used to not even believe they dislocated their shoulders by history, but I found out that I'm wrong with that opinion. So you would evaluate their rotator cuff with an examination or with an MRI? You're only allowed to answer one, you're only allowed to do one of the 2. Well, the first thing I'd do is examine the patient. That's always helpful. And see if they have full range of motion, if they have instability. The guy on the left, humeral head looks a little funny, like he may have a massive cuff tear. The one on the left, the one on the right, I'm not so sure of. So you point out an important difference to me, and that's it. Joe, do you want to talk about one guy being congruent and the other guy not, or?
Sure. The one on the left, he looks like he's inferior sublux, so I'd be worried about his axillary nerve. Most of these things are going to resolve, but certainly that's a concern. And likewise, I agree, he probably has a big cuff tear. Probably both of them do. We know that older folks generally get cuff tears and not labral tears, but I have seen older patients have intact cuffs and actual labral tears with instability. So is there anything on his glenoid side, the guy who's inferiorly translated? I mean, it's hard to see on these things. I'm trying to cue you in, hint. Joe, I'm staying with you. Well, it looks like he may have a Hill-Sachs or something like that. It's hard to tell on that particular view, but certainly you'd have to be concerned about, it's not a great internally rotated view. I'd want an axillary view to know for sure what his true position is. So we're going to call these 2 guys. We're going to call them one Mr. Incongruent and one Mr. Congruent. The congruent guy's on the left. So here's Mr. Congruent, Dr. Esch. He gets his, so this is the guy, he gets his MRI scan. His MRI shows he's gotten a fusion, right? But his subscap and his rotator cuff are intact. So is he done with you? This is the guy. His X-ray is the left X-ray, is the one with the L on it. Actually, I'll go down the line. We're going to go to you, Dr. Field. But his X-ray is this, okay? His MRI is this. He is the guy who dislocated and came out twice more. But he feels reasonably stable to you on his exam.
Over what time period did he come out again?
Oh, in the first week.
Yeah, I don't put a lot of stock in that. I think that muscle weakness can predispose to recurrent instability. You'll see guys that come out 2 or 3 times in a football game and then never dislocate again. I usually wait a number of weeks in a situation like that, especially in this person, a 64-year-old attorney who has intact rotator cuff. I'd probably go relatively slowly and rehabilitate this individual and just see where we end up over time.
Got it. Well, he decided, Mr. Congruent decided to get a CAT scan because I saw something on the, and it didn't appear as well on these projections, but I saw something on the glenoid, so on the X-ray. So he has a fracture, he has a glenoid fracture. Raph, let's go to you. Alan, you'll be last. Now what do you do for this guy?
I mean, it does look displaced, and I would recommend surgery for this and do a arthroscopic repair.
64.
Yeah.
Okay. So here's the other guy, Mr. Incongruent, the one who I think is sitting a little in his deficit. Here's his cuff. His cuff is torn, and here's his CAT scan. And his CAT scan shows, again, not a huge piece, but certainly a perched humerus. So what I did here is on this guy, because he was really incongruent and he had a rotator cuff tear, is I brought him to the operating room, as you suggested. He had a big bony bank heart. I did double row fixation like Dr. Field showed, and put him on, put it back on in a nice way. He also had a reasonably big cuff tear. The other guy, Rafi, who you want to fix, here's how it shook out. 6 months later, the guy who was inferiorly subluxed, I felt that I had to do an operation on because the shoulder was non-congruent, and he got stiff and he did okay. I treated the other guy non-op, and he is as happy as a clam. So I don't know, what do you take away from all that? Dr. Esch, what's your wisdom? What should I have known going into these cases?
I don't know. So first off, I had the 2 guys confused before. So the guy on the left, that's a CT scan on the bottom. Or the guy on the right, that's a CT scan.
So yeah, that's the CAT scan of each corresponding shoulder sitting below it. The guy on the left, I think, was sitting in his defect, okay, on that, even inferiorly subluxed and sitting in the defect, and had a rotator cuff tear in his MRI. The guy on the right just had an intact rotator cuff, but just had a bony bank heart fracture.
And you left him alone, and he's happy. That's good.
So to me, is there anything to get out of this? I mean, I think that you can leave these guys alone. John Levy has a series of about 12 or 13 of these guys, and I think the big difference is that one guy was congruent, one guy was stable in the joint, right? And the other guy clearly was not, and that's sort of what forced my hand. Could I have only done the rotator cuff? And, fixing the rotator cuff in a bony bank heart, I mean, how is that, Alan, how do your patients not get stiff when you do that at age 60?
Well, I'm very aggressive with my rehab, as you know. I get people into therapy within 3 to 5 days, no matter what I do practically. And so I have really good therapists who I work with on a daily basis, and they come into my clinic and we work together. And we coordinate how they're doing and what they do. So we begin passive range of motion within 3 to 5 days. We only keep them in this thing for 4 weeks. And this, absolutely the same thing. I would have done the same exact thing, no different. And so we're very aggressive with rehab. And so most of those issues with stiffness, we're so aggressive with, we don't see very much. However, with what you said here, I actually agree with what you say. Could you have left the bank card alone, done the cuff only? You could consider that, but because he was sitting in the defect, I think you did the right thing personally.
Yeah, I mean, I wonder if I pulled the cuff up alone, would that have been enough for the guy? It's so easy, you're there, you don't want to under-operate, but at the same time, you don't want to over-operate. But again, I think, my lesson itself on this is that I think you can leave a lot of these bony bank hearts alone in this older group, and as long as their joint's congruent, I think that they're going to be all right. And, while many of us think that that's an indication for surgery, I don't know that it has to be in everybody. So next case, a little more straightforward, 19-year-old kid, he's playing rugby, doesn't have has a hyper-external rotation as he gets slammed down into the ground, and has this MRI scan, and I guess you guys can, you want to comment on it all? Start at the end, Raph.
Well, I do see you need axial cuts to see it better, but I see a superior labral tear. The inferior labrum at 6 o'clock appears to have a tear as well, so it could be from 12 to 6 or even a panlabral tear.
So here you are, you look inside his shoulder, and you can see, I don't know if it's projecting perfectly, but his biceps complex and his superior labrum are disassociated from each other, and he's got an anterior labral tear. So, is my pointer good? Right here, you can see the body of the labrum, the biceps complex, and the rent between the biceps and the superior labrum. So, Dr. Escher, you're the tenodesis talker guy, putting in those KFX devices. What are you going to do for this guy? 19.
Does his labrum go down to 5 o'clock?
Labrum goes all the way down around. So it is torn around the front
So I would,
and all the way up into the body past noon.
I would fix the labrum, and I would actually fix the slap in this kid.
How do you fix the side-to-side slap part? What do you do there?
Just put a side-to-side suture in.
What kind of suture?
I probably use PDS in this kid.
So is that routinely across the board? Would anyone use a permanent suture, or would you all use PDS, guys? Al?
For slap repairs, I'm using permanent suture, but looking at that biceps, I mean, it looks like your probe is kind of going through the center of it. Am I seeing that correctly?
Uh-huh.
So, I mean, if I really thought the biceps was damaged to a significant extent, like it looks like this one is, I wouldn't hesitate to do a biceps tenodesis as part of the procedure, because I worry about over-tightening them or creating another problem with a slap repair on those. I know that can sometimes be a problem with these guys.
Yeah. So I'm sure you're right. So on this one, at age 19, and I got a lot of stuff to go through, so we'll go fast. At age 19, I did what Dr. Esch told me to do. I learned that at your course when I was a fellow. I used a couple PDSs to sew the labrum back onto itself. But you really couldn't get an anchor posteriorly because there was still a lot of the biceps intact back there. So there wasn't room for it. And I repaired the anterior labrum as you would in any other way and rehabbed them the same.
So did you think this guy's problem was he had a slap tear, or that he had an anterior inferior